But now we're going to move on to another great individual in our field, and we're going to honor them with the John Niparko Memorial Lecture. So for those who don't know, which I don't know anyone who can be in here and doesn't know who John is, John Niparko was an internationally renowned neurologist, and he really embodied the essence of a clinician, researcher, and scientist. And he was equally remembered for his skill in clinical care, his dedication to cochlear implant research, and his personal integrity and humanity. He exemplified what it means to be a good citizen. He served on NIH study panels. He also served as a founding co-chair of our organization, the American Cochlear Implant Alliance. From a research perspective, John Niparko fostered the largest NIH-funded research study following children who are deaf and hard of hearing who receive cochlear implants, the Childhood Development After Cochlear Implantation Study, it's appropriately named, which involved more than 60 investigators at multiple sites. It feels like an understatement to say that he has influenced all of us during his life or since his passing in 2016. This memorial lecture recognizes his enduring commitment to the cochlear implant field by selecting a keynote speaker whose work echoes the legacy of John Niparko. Since its inception, we've had a series of impressive recipients of this award, including Bruce Gantz, Bill Cronenberger, Nina Kraus, Konstantina Stankovic, Renee Gifford, and Carolyn Brown. And I'm beyond excited to announce this year's John Niparko Memorial Lecture. Oh, it's good, the slide's all up. I couldn't quite see it. And I welcome to the stage Sarah Mizzarelli, who will introduce Ruth Latofsky for us. So thank you so much. Yay for Ruth.
So it is an honor and privilege to stand up here today to introduce Dr. Ruth Latofsky. Dr. Latofsky was my PhD and postdoctoral mentor and remains a great scientific collaborator and a very close friend. In fact, she has been there as a guide and support for me for the past 20 years and is one of the most successful and humble individuals that I know. Dr. Latofsky is a professor in the Department of Communication Sciences and Disorders with a joint appointment in the Department of Surgery and an associate dean for natural, physical, and mathematical sciences in the College of Letters and Science at the University of Wisconsin-Madison. She has held numerous leadership positions, served on multiple advisory boards, and earned several honors in the field of hearing science. Dr. Latofsky is a true visionary and has dedicated her academic career to improving the lives of individuals with hearing loss who use cochlear implants. She was one of the first individuals to suggest that bilateral cochlear implants were vital for children to optimize communication and learning. And in large part because of her, today bilateral cochlear implants for children are the standard for clinical care. This is just one of many examples, and it is safe to say that Dr. Latofsky's work on cochlear implants has had a direct and significant impact on the field of hearing science and clinical practice, individuals with hearing loss, and each one of us in this room. Please help me in giving a warm welcome to Dr. Ruth Latofsky.
Wow, thank you, Sarah, so much for that beautiful introduction. It's really an honor to be here today. This is an amazing organization that I've been following for many years, and I'm really in awe of all the work that you've been doing. I want to thank the organizing committee and everyone who had a voice in inviting me to give this lecture. John Niparko was a friend and a colleague to many of us and to myself as well. John welcomed me to the field of cochlear implants as a non-clinician and really encouraged me to continue to ask questions and do my work, and was really quite supportive for many years, and I have missed him since we lost him. So I also want to thank the NIDCD for funding the research in my lab over the years. And I'm going to begin and end, hopefully, if I remember, by thanking all of the patients and their parents who have traveled to the lab for many years, many, many visits, and who have really leaned into the importance of the research. And without them, we could not have been conducting the work that we have been doing in the lab. So let me see. I need to advance. There we go. Okay, these are my disclosures. So I'll begin by pointing out something that many of us already think about, which is that bilateral hearing, the ability to hear in both ears, provides benefits compared to hearing in a single ear, unilateral hearing. Over more than 2 decades of research in my lab and in other groups around the world have shown that bilateral hearing outperforms unilateral hearing. This is when we measure performance in, for example, the ability to localize sound in the environment, the ability to separate speech from noise in complex listening situations. And also, patients will say that they prefer to use 2 ears rather than 1 if they can, because they feel that it reduces their cognitive load. And we have begun to assess this using measures, including, for example, pupil dilation, which I'll talk about at the end today. So the glass is half full in a way because we see benefits with bilateral compared to unilateral, but the glass is also somewhat less full because bilateral implant users do not perform at the same level as typically or normal acoustic hearing individuals. And I'm going to focus on what are some of the ways in which we can close the gap. There are lots of ways in which there are modes for bilateral or binaural hearing, including our honored guest Jill First's work studying asymmetrical hearing. So we can think, for example, about the most extreme best scenario, which is normal acoustic hearing in both ears, where all the beautiful acoustic cues arrive at the 2 ears and are sent up to the brain with great fidelity. Individuals who are bilaterally deaf, who choose to receive 2 cochlear implants, they're going to hear with electric hearing. And I'm going to focus today on the message that the electric hearing is not coordinated or synchronized across the ears, which is one of the problems. We also have an emerging, as we know, and this is a highlight at this conference, patients who have single-sided deafness, and if they choose to get an implant in the ear, they also have pretty asymmetrical hearing. They're trying to integrate electric with acoustic hearing. And then somewhere here are the bimodal and electric acoustic patients as well. So we think a lot about both bilateral and binaural hearing. When I say bilateral, I mean hearing in both ears with whatever cues you have. And binaural is the integration of sounds and the use of binaural cues, such as interoral time and level differences. So what are those cues, ITDs and ILDs? Well, if a sound arrives from somewhere in a room, say 45 degrees, and reaches the right ear first and then the left ear, there would be an exquisite, very, very small difference in timing of arrival. It's the interoral time difference, which is excellent at low frequencies. And this operates on the order of millionths of a second, microsecond level. And it's really the best cue for localization and segregation of speech from noise. We also have interoral level differences, which are available to bilateral implant users. A sound will be more intense at the near than at the far ear. So the combination of interoral level differences and monaural head shadow are great cues for our bilateral implant users, but they're not as good as ITDs. Now, ITDs and ILDs vary with locations, so if sounds are presented from different locations in the room, different combinations of these cues will reach the ears and be processed up through the brainstem and then the rest of the brain, and that's how we can develop a map of acoustic space. But I'm going to keep coming back to interoral time differences and low frequencies as hopefully the best way to restore good binaural hearing. So what are potential successful pathways to outcomes in individuals with bilateral cochlear implants? I'm going to focus on some of the engineering issues, which is the coordination of cochlear implants in the 2 ears, the hopeful ways in which we can move forward with signal processing so that we can capture binaural cues and deliver them to pairs of electrodes with precision and with great fidelity. I'm going to also talk about early access and the importance of minimizing early auditory deprivation so that good binaural cues can be delivered to children as they develop. And I'll show you some data from our adults that speak to that. And then I'll end with some thoughts about top-down processing and minimizing cognitive load as well. So when we think about sound localization, and we have an array of loudspeakers in a room, I want to start by showing you some very typical canonical data from many studies we've collected over the years, highlighting 3 studies here, and the involvement of Erica Bennett, Tina Greco, Caleb, and Yi Zhang in these studies was really fundamental to the success of the studies in either children who were 5 to 12 or even little tiny kids, toddlers, who we taught to reach for sounding objects. What you see here, which is very typical in a normal hearing child, is the response as a function of target location is excellent, with very small errors or jitters around the diagonal, the line of unity, and average error can be as low as 10 or even 5 degrees. And very typical for bilateral implant users, you could see a lot of jitter around the diagonal with errors that can average between 20 and 40 degrees, and they never look really as good as the acoustic hearing children, although listening with 2 implants is almost always better than listening with 1 implant. We also have done quite a few studies on adults, and some of the more recent work with Sean Anderson and Heath Jones also shows the benefits of bilateral implants. Again, normal hearing individuals are really excellent at localizing sound with very small average error, but bilateral implant users have this jitter around the diagonal, as if they're not always sure from trial to trial exactly where the sound is coming from, and the best average error is around 30, sometimes 20 degrees. What about separating speech from noise? We have to function in complex acoustic environments. Children are studying in noisy classroom environments, and we also socialize in noisy rooms. And so a great example is, say, there's a room full of some adults and students who are learning, and this child might be trying to concentrate on the conversation happening over here, but there's another conversation happening over here, and the child can maximize their success if they can suppress or ignore what's going on here and focus on this conversation. Similarly, in a restaurant environment, we're all familiar with the fact that it's very hard to listen and focus on one conversation if there's a lot that's going on around us in the restaurant. So in these cocktail party or classroom environments, we have studied, and many other groups have studied, the involvement of both bottom-up processing at monaural and at brainstem and binaural levels, and also top-down attentional and cognitive networks. And I want to focus on just a couple of studies from our lab that really speak to the binaural bilateral issue. We simulate this environment by placing a child in a soundproof room, and we could present a sound in quiet. And the important thing is when we present a masker, an interfering sound that is from the same location co-located, you have a big effect of masking. The question is, can you somehow release from that masking? So if we move the masker from the front to the side, this separation, which gives spatial cues or different location cues, provides what we call release from masking. And in our studies on effort, we're looking at whether we get a release from effort. So I'm going to focus just on 2 studies. The first was from Sarah Miserelli's dissertation. And in that study, she had the target speech in front. The masker was either on one side. This is an asymmetrical separation like you saw on the last slide. Or there might have also been a masker here on this side as well, which is a symmetrical condition that forces you to rely on binaural cues, whereas in the asymmetrical, you have both bilateral and monaural head shadow. And here's the story. In these 2 groups, which are 2 groups of children with implants just at different ages, we have very little release from masking. The y-axis is spatial release from masking, so high numbers is better performance. A little bit higher in the asymmetrical, where you also have head shadow. The 2 groups of children with normal hearing show much bigger effects, especially in the condition with both with the asymmetry, but they also show an effect of symmetry, which means they can use binaural cues to benefit from spatial separation, similar for adults. Now, this is a 90-degree separation where you also have monaural in addition to bilateral cues. Very recently, Ellen Peng, who was a postdoc in the lab and is now at Boys Town, published a different paper using a different methodology in which we had head-related transfer functions, or virtual space, and we could control whether children had binaural or monaural cues. But she also, in the data I'm showing you here, put the masker all the way at 90 degrees separation from the speech target. And with this 180-degree, totally across the head separation, that's where she started to see much bigger benefits. So children with 2 cochlear implants had bigger benefits than we had seen here, average of 8 dB compared to just a few, still worse than children with normal acoustic hearing. So there's a gap here, but this 180-degree under binaural conditions activates the binaural pathways. Now, it's not a condition we would experience in everyday listening situations because often the target and masker are closer to one another, but this is where we see the maximum benefit for these kiddos. So the gap in performance which we observe, we think is likely due to the fact that bilateral cochlear implants do not provide binaural cues with fidelity. And I'm going to focus on that for much of my talk today. So we think about the engineering of the cochlear implants, the need to coordinate the implants in the 2 ears, and possibly develop signal processing strategies that might capture binaural cues and deliver them to pairs of electrodes across the ears with precision or with fidelity. What are some of the limitations that the field has discussed to date in bilateral implants? Well, the 2 processors function as independent they have independent time clocks, basically, so there's no obligatory coordination. But even when we've done studies in which we've obligatorily coordinated just the input to the devices, what we see is that there's no deliberate matching of the actual inputs. The programming today has not developed to that extent. So the brain is looking for inputs that are coordinated by frequency and matched across sites in the cochlea with great precision. And so that is something that we still need to work on. We don't know, but it's possible that there may be a mismatch in the insertion depth that we have not yet understood or accounted for. And we all know that monopolar stimulation, which is what we have to use nowadays, creates a spread of current, which has an excitation pattern that spreads over millimeters in the cochlea, and that interferes with selective stimulation. So what can we do? Well, let me first start by mentioning this study by Stephen Dennison, who was a PhD student in the lab. And what Stephen did is he took implant processors, put them on a mannequin's head, and presented sounds from in front, and measured to see what individual electrodes do in the response. And this is a click, just a train of pulses in one pair of electrodes with a clinical processor. What he saw is that the left and the right electrodes are responding at different times, even though the sound is coming from in front. And from pulse to pulse, they're not even consistently different. So the inconsistency is inconsistent, or the mismatch is inconsistent. If we use synchronized research processors, we immediately get synchrony. So we can control the timing of the inputs to specific electrodes today only with research processors. And so I'll tell you about some of that research. But I'm going to focus on the role of experience, or the idea that we might want to minimize auditory deprivation as we study these effects and think about future directions. So Tanvi Tucker and Sean Anderson, who did their PhDs in the lab, published a couple of nice papers in which they talk about patient-based biological factors and some of the negative impact on binaural processing. Whoops. Sorry. How do I go back? There we go. Okay. The factors are many, as you know as clinicians. There are so many things that we have to think about in our patients. But as you think about lifetime from birth all the way to older age, here are some of the aspects of these factors that we have identified and been thinking about. Of course, I'm going to focus in my next slide on the age at onset of deafness, which seems to be very important for binaural hearing. But we also have the years of acoustic exposure before deafness, the years of bilateral hearing, when they got their first or the second implant, how many years with each, either one cochlear implant or both. And it turns out the age of testing also matters. In one of Sean's papers, we showed that as people get older, their binaural sensitivity is worse. Okay, so how do we do these studies with our research processors? So here you see what might look familiar, or this is a train of clicks presented to one electrode in one ear, and then another to the other ear. And you could see the intraoral time difference here is on the order of microseconds. And we ask patients to tell us if they can hear a change in the sound moving across the head, left to the right or right to the left. Or in the next study I'll talk about, we ask them where in the head the sound is perceived. Notice that these are low rate pulses, 100 pulses per second, which we don't program patients with those low rates, and I'll talk about that in a minute. But whether we measure performance in the apex or in the middle or in the basal region of the array, the important thing is that individuals with adulthood onset of deafness tend to have lower thresholds. This axis is the intraoral time difference threshold. So low numbers means good performance. And some of them are as low as about 100 microseconds, which is where we see normal hearing adults fall. But generally, if adulthood onset of deafness will lead to lower thresholds than childhood onset of deafness. In individuals whose onset of deafness was during childhood, we see a broad range of sensitivities, and some could not do the task. They had no access to ITDs. What we have found in our studies over the years is that ITDs are vulnerable to deprivation early in life. I'm not even talking today about intraoral level differences, because even individuals who had onset of deafness in childhood, didn't hear for many years, and then got their implants as adults, can regain access to ILDs. The brainstem is able to reactivate those circuits, and those are cues that they get through their implants. So ILDs are more easily restored, but ITDs are vulnerable to deprivation, and they're the cue that we would like to be able to restore. And why? Well, one way to think about it is that depriving young children of binaural cues early in life, even if they get 2 implants, they're not getting binaural cues, might limit the potential for the development of the binaural pathway. And starting from birth, this is my youngest homegrown sample with a couple of hours after birth, she's turning her head toward my voice. Infants are seeking information from the environment. They're turning their heads within hours after birth looking for information, and localization emerges in the first year, 2 years of life, and becomes really exquisite. So if we miss this opportunity, then the binaural circuits may not regain that ability. And there are compelling reasons to see, therefore, if we can design new binaural strategies so children can receive clinically these strategies early in life. Okay, what I'm going to say now is preaching to the choir, because we all know how cochlear implants operate, but I want to focus on what the pulses are doing. So the speech here is going to enter the implant processor. It will be divided into somewhere between 12 and 22 channels. You see here the beautiful speech spectrum in each of these channels. And we have the temporal fine structure, which we discard. We also have the envelope, which is the slow-moving change in amplitude. And what the implant processors do is take away the temporal fine structure and replace it with pulsatile stimuli that are high rates. And these high rates are about 1,000 pulses per second, give or take, some hundreds, but they're not 100 pulses, which is what we need for ITDs. So what we think about is this limitation of fixed rate carriers at all of the channels at these high rates, which won't work for preserving low-frequency ITDs. Our goal, therefore, for new strategies is to try and see if we can encode low frequencies for ITDs with a temporal fine structure that we took away, and also retain speech envelopes so people can understand speech. We want to localize and hear speech and close the gap relative to normal hearing listeners. So one idea is to have a mixed rate of stimulation, and we've been doing a number of studies trying to address this topic. And here's the idea. If we can send and encode low rate frequency ITDs to 1 or 2 or 3 channels and leave the rest of the channels for speech understanding, we could retain speech with the envelope cues at these high rates of stimulation. So these mixed rates have been tried by us and by some other groups, and I just want to tell you about some of the proof of concept that we have been finding. So in this novel signal processing mixed rate strategy, what we do is we send ITDs to very specific select pairs of electrodes to see if we can improve binaural hearing. This was part of Tanvi Tucker's dissertation. So in this study, though, she's asking people to tell her where in the head the sound is. Is it over here or here or here? And so the lateralization range, if it's large, which would be up here, if they're using the entire extent of the head, that's better. If they only hear sounds at one location and they can't quite lateralize, that would be down here. So that's not so good. Now, when we sent them, here we have a bunch of electrodes, and we have pairs of electrodes along the cochlea, and we pitch match those electrodes. And when we present high rates to all of the electrodes, we see terrible lateralization. Patients cannot tell us that the sound is moving to different locations in the head. So that's not good binaural hearing. But when we replace those with low rates, 100 pulses, at all of the electrodes, we see excellent lateralization for a lot of patients, and some remain not so good. And I'm going to tell you, I think the reason they're not so good is that some of the low rates are not presented to electrodes that have really good neural health. And I think that trying to find electrodes where neural health has the best survival is going to be one of the keys to excellent outcomes. Now, okay, so what we then, I'm going to take that away for a second. So what we then do is we use mixed rates. So to take a look, for example, at when we introduce one electrode with low rates in the middle of the electrode array or in the base, we see that lateralization has recovered to what we saw with all the low rates. So this kind of a mixed rate strategy, or where we spread them across the electrode array. We also have interleaved where every other electrode is either low or high rates. And when we have these mixed rates, we see recovery of ITDs to these levels compared to what we see with the clinical rates. So this is to us the proof of concept that inserting low-rate ITDs at even one or more electrodes can restore binaural ITD sensitivity to what it was with all low rates. But we need to study the role of the health of the cochlea so that we don't see these poor performance, and we can bring everybody up by sending the information to the best possible electrode combinations. Okay, so I talked about engineering and some of the ideas that we're thinking about and early access to minimize auditory deprivation. And the last thing I want to talk about is the idea that top-down processes, I mean, the brain, is really involved in what we're doing. And so we have to think about attention. We have to think about how to minimize cognitive load and listening effort. And we also have to think about how we integrate audiovisual information. So what I'd like to do is to focus just a little bit on this question of cognitive load and listening effort. And the idea is that we're going beyond % correct. We don't want to just ask, how many words did you get correct? Or how well can you localize? What is your root mean square error? We want to understand when you can localize or when you can understand speech, what else is going on? And there are a number of methodologies that our lab and others have implemented over the years. For example, we have used functional near-infrared spectroscopy to image frontal areas of the auditory cortex and then non-auditory areas to look at effort. We've also used real-time processing using an eye tracker where we track the eye gaze to measure what the efficiency is for how well children and adults can find the sound, the interoral time difference or the interoral level difference. And we also use pupillometry. And I'm going to focus now just my last few slides on the pupillometry studies that we've done. And these folks whose photos and names you see here did the seminal work in the lab. And pupillometry is basically a proxy for listening effort. Why do we use it? Well, pupil dilation varies with the activity in the autonomic system that regulates attention. It is related to arousal state, our ability to attend to the environment, sort of a flight or fright situation. It's controlled by norepinephrine. It's automatic. We don't control our pupil size, But somebody might say, wow, your pupil is very dilated or very constricted, depending on the environment. And there are individual differences, and differences with hearing loss and with age. So what you see here is Emily sitting with her head fixated in the eye tracker, and she is listening to sounds coming from loudspeakers and looking at she's fixating on the screen. And so the way this experiment works is that we have people listening to sentences, and the time relative to stimulus offset is what we see. So here's a baseline measure. The stimulus is happening here. You see a rise in pupil dilation, and then we wait a bit, we get them to respond. And so we're analyzing whether they have more effort, i.e. more pupil dilation, or less effort, less pupil dilation. And effort also means engagement, or it could be fatigue, right? Is it costly to do the task? But I want to tell you about one study, actually in individuals with single-sided deafness. So these patients came to see us before they got their implant. We measured a whole bunch of outcome measures in them, and then they came a year later after they got their cochlear implant. And so I'm going to show you some data on spatial release from masking and its association with release from effort. So in this study, we either measured performance with speech and maskers co-located or separated. And so remember, when we go from here to here, the benefit would be release from masking, i.e. better speech understanding, or release from effort, which could be reduction in pupil dilation. So what are some successful pathways to outcomes when we think about all of these things? Well, maybe in an ideal outcome, we'd see that adding a second ear would improve spatial hearing. We've seen some of that with bilateral implants, and we see it with SSD-CI patients as well. Ideally, we'd see improvement in speech and reduction in effort. We might also see non-ideal possible outcomes, which is maybe they're better at localizing sound, not so good at speech, and adding the second ear increases effort, or maybe everything gets worse. So patients are going to vary in what kinds of outcomes they're going to give us. But I'm going to show you one slide. This is under review right now. We hope it will be accepted. But basically, in this very small group of patients with single-sided deafness who got a cochlear implant, we tested them a year later. What we see is that the spatial release from masking, of course, varies. But as people get more release from masking, they're getting more release from effort. So there is some association here. Some don't get good release from masking, those folks down here, right? And they're not going to get good release from effort, but there is an association. So in terms of top-down processes, well, I'll start here because these are my conclusions and future directions. So we've observed benefit in localizing sound, in speech understanding, in noise, but the improvements can be small, and we need to close the gap relative to normal hearing acoustic listeners. In the clinical intervention space, early access definitely helps, as we know, but the engineering needs to be improved because early access to acoustic binaural hearing and minimizing auditory deprivation might help us maximize success. And finally, when we think about top-down processes, do they help with spatial separation? Do they help with other aspects of difficult listening conditions? Well, maybe in addition to clinical and typical research tools, one day we could assess cognitive load and listening effort in the clinic on an ongoing basis using some of these tools. And I also want to mention a research tool that is going to be part of, I think, the way in which we can maybe understand the future engineering. This is called the CCI Mobile. It's a portable processing platform that we are collaborating with folks in UT Dallas and NYU on using to implement some of these strategies and hopefully be able to send folks home, give them experience with novel strategies, and see if we can improve outcomes. I want to end by thanking my incredible lab because they do all of this work. These are folks who have been in the lab over the years, and this is a recent photo. You could see Sarah and her daughter by the lake in Madison, Wisconsin. So these are lab members and collaborators, and of course the NIDCD for support, and some older photos of folks who have left the lab but contributed beautifully to the work. I want to thank you again for allowing me to speak with you today, for the keynote, for your attention, and thank you so much.
Amazing. We have something for you. I'm terrified I'm going to drop it. So thank you so much. That was a very incredible summary of your work and inspiring for not only what we know, but where we're going with it. So thank you so much. And as a token of our appreciation, we have this lovely bowl for you. It's not just a pretty, oh, I should talk into this. It's not just a pretty bowl, but it is from one of John's favorite glass artists. So it's quite special. So thank you so much for everything you do.
Thank you very much.
Thank you very much. Thank you for your attention and for coming to the opening session. We hope you have a great conference. And now please go get some caffeine at the coffee break. So thank you so much. We'll see you around.